biceps lecture. So we'll talk about rotator cuff interval scar in the next lecture on inflammatory disease. Why don't we start here? Sean, what do you think of this case?
It looks like there's some anchor tracks in the humeral head, and the bicipital groove looks very shallow and deformed, and I don't see the bicipital tendon within the groove, suggesting it's either been torn or severely atrophic and subluxed.
Right.
And you wonder if there might have even been a tenodesis lower down, but
yeah, so that's exactly what happened. And as John said in our last lecture, very often disease of the rotator of the biceps is associated with rotator cuff tears. Actually, the rotator cuff tears are often the primary pathology, and the secondary injury is the biceps tendon. This is actually part of a supraspinatus tendon repair here with that suture anchor. This suture anchor is in the bicipital groove, which is right here, and this is the long head of the biceps tendon coming up, and it's been Tenodesis to the bone with a suture anchor in this location. Here's just another example, 50-year-old with biceps tenodesis, interference screws 2 years ago. He fell, and the concern was there a rupture of the attachment there? And if we do an oblique coronal image, we can see that the construct is intact. So tenodesis intact, so it wasn't torn. So I think this is probably where we ended up last time, actually. This is a 77-year-old male with shoulder pain. Ram, what do you think of this case?
We're looking at two axial views of the proximal humerus at the level of the bicipital groove. So the biceps tendon appears, at least at this level, intact, nice and round in appearance. However, there's another large structure within the tendon sheath adjacent to it. It's low signal. It changes signal, fat saturates out. It's probably a loose body of some sort, a loose body within the biceps tendon sheath.
Yeah, so remember the tendon sheath communicates with the joint space so that you can get loose bodies there. This one, if you actually look at the configuration and so forth, remember loose bodies, once they're loose, they can actually continue to grow. My guess is this has probably been there a long time, and the way it actually grew in a configuration which would allow the biceps tendon to continue to function. But that's a loose body in the biceps tendon sheath, so they can occur there. Plain film here. Michael, what do you think of this?
Okay, so we have skin AP and all right, so on the plain film, looks like the shoulder's articulated. There's soft tissue kind of prominence adjacent to the humerus here, and then on the MR, we have abnormal signal within the muscles here. Should figure out where we are exactly. Okay, so it looks like it's anterior to the humerus. Synovial. Okay.
So these are multiple calcified bodies along here, and there's kind of expansion of the synovial lining here of the long end of the biceps tendon, and this turned out to be synovial chondromatosis, metaplasia of the synovium into chondroid tissues. Yuri, what do you think of this case?
Okay, 40-year-old with anterior shoulder pain after working out. So we got two axial views of the left shoulder. The biceps tendon looks a little bit elongated, and there's abnormal signal intensity in the expected location of the coracoid process. It just looks very heterogeneous. On the oblique coronal views, again, there's abnormal signal in the region of the coracoid process. I think the short head of the biceps tendon probably has been injured. So I would
I'm
want
not sure
to.
we're seeing that real well on these images. Certainly you can see the long head here, and there's some fluid around it. We can certainly see there's this collection that has a lot of what kind of focal areas of low signal intensity within it, something along the lines like rice bodies, kind of a speckled appearance, which we can see on multiple images here. It really extends down into the arm. So what do you think that this collection is?
Oh,
This is the
probably represent,
subscapularis.
right. It's probably osteoarthritis tracking into the.
Yeah, this was synovial chondromatosis. It was actually involved a little bit of the biceps tendon sheath, but the bulk of this was in the subcoracoid bursa. Okay, Sean, what do you think of this case?
Two coronal images, and there's kind of a fusiform fluid collection. Again, it looks like it's tracking along the bicipital tendon sheath. But it also, you wonder if it's actually within the biceps tendon, so it's probably myxodegeneration or developing sister ganglion within the long head of the biceps tendon.
Yeah, that's exactly what it turned out to be. I would have thought that this, maybe this is a bit of tendon here, but maybe this is completely disrupted and distally retracted. But what this turned out to be, this is the tendon, that's the tendon there, and this was a big intratendinous cyst filled with mucoid tissue. So this was an intratendinous ganglion within the biceps tendon.
Is that happening? Is that a consequence of like injury and tearing, or is that just a developed de novo?
Yeah, it's probably injuring and tearing, and it's a form of degenerative type disease, but it's probably caused by intrasubstance interstitial tears, a lot like the mucoid degenerative cysts that you can see in the ACL. Okay, let's see who just joined us.
I did.
Oh my gosh, Susie joined us. Great. All right.
Yes.
Okay, let's see. Michael, why don't you take this case?
Okay, it's chest pain looking for a pectoralis tear here. Looking anteriorly, the pectoralis muscle kind of looks like it's a lobulated appearance here. Okay, and then we're showing tendon attaching to the humerus, and that's the normal side, I assume. And then we're showing. It's the same side. Okay, so it's not actually a. I see. Okay, so that lobulated appearance I was looking on the T1 shows a lot of fluid and edema within the pectoralis major muscle itself. So I think this is actually a tear of the pectoralis major muscle, and the tendon looks like it's inserting okay.
Yeah, and the important thing in these is really to differentiate exactly where the tear occurs. In general, if it's a muscle tear, it's not a surgical condition. John can correct me here if I'm wrong. If it's a tear of the tendon off the bone, then that's generally a surgical condition because that won't heal. And you can sew that or put it back on by suture anchors or K-wires back into the bone. Jonathan will get my air here in a minute too. Whereas with the muscle, you really can't repair that, and it can heal on its own. So differentiating that is very important. Now, the thing about the tendon of the pectoralis, that's a huge muscle. It's, as we already know, it's responsible for a lot of activity, power activity in sports, including pitching. But it turns out to be a very thin tendon, but it's strong because it's a very thin but a very long tendon. So it's more of a sheet attaching to the humerus. Uh, and if that's torn and ripped off, then it's generally surgery right away before you get a lot of scarring. If it's at the musculo-tendinous junction, then there's can be a lot of debate. But if it's within the muscle belly like this, it tends not to be a surgical condition. John?
The tendon can be repaired, especially if it's from the bone, but the muscle obviously cannot. What's interesting that I have seen
people with, even, I'm not talking about women, but men with, especially from Hollywood, with implants. And so that's something to think about. But that's Hollywood.
In the mass section, we'll see some insight.
Do we, even if it's a very large tear and there's separation, there's never a time you'd put in some suture, maybe just to oppose the muscle fibers, or they find their own way back somehow?
If you do, it'll just tear away, and then you'll have more scar than you want. So then you have a surgical scar, and then also a skin scar, and scar in the muscle. When you tie your sutures on muscle, you're tying through mush, and you're strangulating what's left there that you put the needle through.
Okay, and then here are just the sagittal images showing the tear within the muscle itself. So this is generally considered a non-surgical lesion, conservative treatment. Here's another patient.
I'm sorry, Dr. Cruz.
Yes.
What do you do with myotendinous if it's torn at the myotendinous junction? What's the treatment?
At the myotendinous junction, what's important is to look at the quality of the tendon at the musculo-tendinous junction. If there's a substantial nubbin of low signal intensity fibrous tissue there, then it may be surgical. The surgeon may want to go in and evaluate whether they can repair it or not. If you really don't see any tendon on the muscle side, then there's a pretty low chance that you can do surgery. So there could be a discussion, but typically, and again, this isn't completely an imaging decision. A lot more goes into it clinically than just the imaging technique. But the common rule is that if the tendon is torn off the bone, it's a very good surgical result. If the tendon itself is torn, generally surgical result is better than non-surgical result. Musculo-tendinous junction or muscle tears typically most of the time are treated conservatively in my experience.
Okay, thank you.
If you don't have anything to purchase your needle and suture to, you just cannot do it. It's like sewing Jello. Try it sometime. It's not going to work.
Any other questions? Okay, so now here's another case on a low field scanner, but here if you notice on the axial images, this is the pectoralis. It's proximally retracted. There's the tendon, and we can see there's been a tendon tear off the bone. The tendon should be a nice, smooth structure that goes over and attaches to the bone in this location. There's the long head of the biceps tendon. And then here on the oblique sagittal images, this is the biceps muscle. This is that distal tendon that's pulled out and waving in the breeze of the tissues and the hematoma around it. So, Aram, is this a reasonable surgical case or non-surgical?
Yeah, given that it's a tendon disruption, I'd say this is surgical.
And it was treated by surgery. 16-year-old American football player chest wall plain after a blocking injury. Now here we can see that there is distal tendon attached to the bone, and here's the proximal muscle retracted. This is probably a little bit of not normal tendon here, but there may be a little tendon nub in that location. But you can see it's proximally retracted back to there. Here's the other images. And if we go to the stir images, we can actually see that probably is a nubbin of tendon in that location. Here's the distal tendon over here. So this is probably a proximal tendon injury. And these are the kind that may or may not be surgical. There may be enough perch power here where you can go in and operate on this individual, maybe not. They decided not to operate in this particular case. And he was actually a potential high draft choice. And I believe this was not very long ago. And 16-year-old. And locally and where he's from, they wanted to operate. When he was referred in locally here to us, I think the decision was to do it conservatively. And actually, I'll try to follow up next week with see how he's doing right now. I believe this was just about 6 weeks ago, but I believe that the decision was made to treat this person conservatively.
I have no quarrel with that. If you can go up and down in terms of acquisitions and see how broad that tendon is. If if you have only one cut, that's I would treat it conservative.
Okay. See, and that's the next cut, and there's just that one cut that we could see a nub of tissue there. Here's a 24-year-old weightlifter with current right chest wall pain. Now, this is one where on the T1 weighted image, we can actually see that there's some high signal here near the musculo-tendinous junction. That means that that's fat there. But if we compare it to the T2 weighted image, there is some fat there, but also there's more increased signal intensity on the T2 weighted image, which means that there are some cystic fluid collections adjacent to the fat. And here we go on the sagittal images. Here is a chronic defect within the pectoralis major muscle. And here we can see a little bit of fluid in that area. But this was someone who'd had chest wall pain for some time. And what this turned out to be is someone who'd had recurrent tear that had scarring and healing with some fatty replacement in the area, and then had a tear on top of that. So now he had an acute on top of chronic situation, and this is an acute hemorrhage, and this is a little nubbin of tendon here, and then we can see that the muscle is protracted back, but we really couldn't find a good piece of tendon on the muscle side in this particular person. Since it was an old injury with a new tear on top of it, they elected to treat it conservatively, not do surgery, because we really couldn't see a good nubbin to sew to.
I don't think this guy's going to be an all-American weightlifter, body beauty contest type.
He's trying.
He's not going to be World America or
Mr. Universe is a 64-year-old female with shoulder pain. Susie, what do you think of this case?
Can you hear me?
Yes.
Oh, great. I finally got this microphone working. Well, it looks to me like she has ruptured her subscapularis tendon, and maybe the biceps tendon is also, it just looks like it's, yeah, where your arrow is. So I'm not sure if it's both tendons or just her biceps. I'm not sure.
Okay. You're talking about this area in here. And quite frankly,
Yes, that's right.
I forgot. Looking at these one images, I'd have to agree with you, but I don't remember the other images up and down. In this particular case, what I'm concerned about is what do you think this area of abnormality out here is, adjacent to the coracoid process?
I have to admit, I'm not certain.
Okay, here are the sagittal images.
Okay. Oh,
What's this right here?
that looks like it's the
That's a
I
short
think
head
it's
of the biceps.
biceps, right? Biceps muscle?
Yeah, the short head of the biceps comes up and attaches to the inferior coracoid tip.
Oh, okay,
So what's
sorry.
happening over here? That's fine.
So then it looks like there's some fluid that's coming up into the a partially ripped tendon, and the muscle is strain. Okay.
Okay. So this is actually the pectoralis minor.
Oh, okay.
Not commonly torn. And I hadn't realized I had this case because one of the orthopedic surgeons called me the other day and asked me if I had a pectoralis muscle strain for a chapter he's writing, and I told him I didn't. So I'll have to go back and get back in touch with him. But that's where the pectoralis minor is, and you can have tears of that too.
Okay, Susie, how many tendons attached to the coracoid process?
Hello?
Ask again.
How many tendons attached to the coracoid process?
Susie.
Biceps.
The answer is 3. Short head of biceps, coracobrachialis, and pectoralis minor. And there's a lot of fascia around there, but we don't see the fascia on the MRI too often.
I didn't know about the coracobrachialis. That's
Okay, well, that's the end of the biceps lecture. Any questions?
Neither the Campbells until they wrote the editor a letter and told them that it's not radiobrachialis, but coracobrachialis.
just in this case that's up right now. So is that a fluid collection near the myotendinous junction of the pectoralis minor? What are we seeing on that?
Yes.
The T2. So it's torn. It's not just strained.
I think it's torn.
Yeah. Well, to really determine whether it's torn or strained here, I'd have to go back and look at the individual images to see whether you could follow the tendon through here. Here's the nubbin of the distal tendon. Most likely it's torn, and there's a little bit left here, but the tendon is torn there. But you really need to look at adjacent images and see. And I don't remember this case, but what did I say it was here? Well, I must have been able to follow it because I felt that it was not a complete tear, so I used the word strain. So in this particular case,
Quite irrelevant because you're not going to treat it. You don't treat these.